Hi, Dr. Donald Jervich here, and we are looking at part 2 of the geriatric 4M of medications. This is part of the program for the Dakota Geriatrics and the HRSA-supported Geriatric Workforce Enhancement Program to strengthen older adult health care. The goals for this presentation include how do we screen patients for unsafe medications, how do we optimize communication for deprescribing, and then how do we ultimately eliminate or reduce the burden of unsafe medications in the older adults. So I think we could legitimately ask is there a deprescribing process? I think we do this frequently informally, and the question is there a way that we can more clearly systematize the process and make it more consistent as we practice the 4Ms with each clinical encounter. So maybe a little trite, but just what is the definition of deprescribing? And so from one article here, we call it a process of withdrawing inappropriate medications under the guidance of a healthcare professional with the goal of improving outcomes. And so we always need to ask, what are those outcomes? And I'll share with you one of the process measurements that we can judge ourselves or analyze how well we're doing with the deprescription process as part of a quality improvement initiative. So in terms of communication with the deprescribing process, we had mentioned earlier in the other presentation that we want to be mindful of the psychological connection to prescriptions that people have. We also want to promote, as in all aspects of clinical care, a shared decision-making process, which, by the way, should also include the caregiver. We often overlook that. And from my perspective, and you might have a different approach to this, but I think as an icebreaker, when reviewing the medications under our 4M framework, I always ask is whether one or more of these medications, are they making any difference for you, or are they helping you? And if you get sort of a head scratch moment, that might be an opportunity for deprescribing or exploring the possibility of discontinuing a medication. We just want to emphasize the psychological connection to medications. One of the, these are different quotes from a quality data research program, and you can see the different responses that the patients have had when asked about this. One of them, the second point here is, do you know what you're doing? If you ask about taking away a medication, people might challenge you in your knowledge because one of their doctors from a long time ago, gave them this and said they have to be on it for life. So again, there's a lot of points here that we need to be mindful of and respond to as we interact with the older adult. There's different methodologies for deprescribing, but I found this JAMA article from somewhat recent that walks you through the steps of firstly establishing the medications and what they're used for. A lot of times I'll ask somebody, I say, why are you using this gabapentin? And I go, I don't know, my doctor gave it to me. Or some other medication, and just reflecting it, they don't have a connection as to why they're taking it, but they're somewhat dutiful in following doctor's orders. The other one is to determine, number 2 here is to determine overall risk for drug-induced harm, and that's why we have these lists such as the Beers list to identify classes of medications that are clearly harmful to older adults or potentially harmful. And then the third point is that medication absolutely needed, or is it something that we could consider discontinuing? So that's particularly in the case of SSRIs. If you are treating mild to moderate depression, there's probably a higher likelihood that you can try to reduce or discontinue the medication, as opposed to somebody who has a history of severe depression, where they may need more long-term use of it. Number 4 is to identify the and triage the medications that you would like to discontinue, and do it in small steps. Don't get rid of all the medications all at once. This is an approach from actually Australia drug management system, and the question is who should be and when, how medications should be deprescribed. In this instance here on the left with the who is certainly people who are frail and individuals that have chronic kidney disease or advanced chronic kidney disease. The deprescription process should occur at all junctures of healthcare transition, particularly, for instance, when a patient is being discharged from a hospital on an antipsychotic that was used for delirium. There should be a hard stop date if they're transferred to the long-term care facility, as an example. The process is enhanced by what we call a brown bag audit. I used to do these in the community setting when I was in North Carolina. In Durham, I would go to public housing and I would sit down and just meet with folks on a one-on-one basis to review their medications, and we would do an advisory. We didn't deprescribe, but we suggested that they talk to their doctor about medications that the geriatricians thought were perhaps unnecessary. And then finally, the documentation. And so that's why we document the 4 M's, right? So under medications, you list what the unsafe medication is, and then yay or nay as to whether you want to deprescribe it and the reason why. Yes, the SSRI is an unsafe medication, but it is necessary for maintenance of therapy for depressive symptoms. And of course, that comment would complement what you're saying or evaluating in the other 4M of mind, where you would then document the PHQ-9 to show that you are adequately maintaining antidepressive therapy, because the PHQ-9 should be 4 or less. One of the questions is what is the deprescribing efficiency or efficacy? And I thought this was just kind of an interesting study here, where you can see from 65 to about 80, there's a massive peak in prescriptions that occur, and then as people advance beyond average life expectancy of the age of 81, those prescriptions decline, and I would conjecture that the people that are surviving to 81 and longer are actually very healthy, long-lived individuals who don't need a lot of medications or have a low chronic disease burden. So there is ample evidence that deprescribing works. There's been meta-analysis and multiple studies. One of the studies cited from Australia showed that with a dedicated deprescribing program, that you could reduce the overall medication on average by 2 medications after the process. Geriatrics works. So the first point here is that in one study that there was up to 4 fewer medications, and as a result of that, there was a better quality of life reported by the older adult participants in the study. There's been several studies looking at antipsychotic reduction, and in these studies they show that the reduction had no impact on change in symptoms. It actually helped reduce falls and had small incremental improvements in cognition for those transitioning from antipsychotics to not taking the antipsychotics. And I'll just, as a sideline, state that here in North Dakota, our nursing home patients still persistently have high levels of antipsychotic use relative to the national norm. So we have a lot of work cut out for us to deprescribe antipsychotics in long-term care. So Some folks got a group of geriatricians together and asked them, well, what are the medicines that you don't like? And so here's the list. Top of the list, and just about everybody's list, is benzodiazepines because of their potential for cognitive impairment, amnesia, and fall risk. Same true for atypical antipsychotics, which some research indicates that about 13 to 15% of dementia patients will benefit from antipsychotics in terms of behavioral control. But again, it gets back to that whole issue that the vast majority of the individuals with agitation in dementia do not benefit from antipsychotics over the long run. Statins, particularly in the oldest don't make sense. Tricyclics have side effects including hypotension. PPIs, they're number 5, are associated with community-acquired pneumonia, increased incidence of that, osteoporosis, and now some new indicators of cognitive impairment, and so on. And you can see the list there. I don't know why opioids is number 9 on the list, but I think as part of our project for age-friendly, we want to identify potential opioid misuse and to educate people on deprescribing that class of medications. So when you do your assessments, I think most people refer to the Beers list. There are other tools that could be used, but the 2 systematic tools that have been used are the Beers list and then the Start-Stop program, which is generated out of Ireland. So here are some of the targeted medications in addition to that consensus list that I showed you. We want to be mindful of the first generation antihistamines and the dreaded Tylenol PM. And I have one of our geriatric fellows who so proudly said that I asked them if they take Tylenol PM, and the patient reported that they did. And so we talked about deprescribing. So, winning a few battles here and there. The sulfonylureas certainly are associated with hypoglycemia and are to be avoided. That's why metformin still, despite its side effects, continues to be the first line treatment for type 2 diabetes. I always emphasize vitamin E simply because it increases the risk for hemorrhagic stroke, and there is some research that suggests that chronic vitamin E use shortens your lifespan. Multiple vitamins probably are not necessary, with the exception of maybe vitamin D supplementation. And then the whole question of duration of bisphosphonates, because they're they last for an eternity in the bones, and it's not clear that long-term use of bisphosphonates changes outcomes. And then we talked about the PPIs. Also, be mindful of what might happen, for instance, when you prescribe high-dose prednisone. It is perhaps one of the most anticholinergic medications that we prescribe, and it can predispose people to delirium or mental status changes. The dreaded amiodarone for cardiac arrhythmias, atrial fibrillation, and so forth has a high impact on older adults, on fatigue, and the well-known drug induction of hypothyroidism. Nitrofurantoin is a tricky wicket because it's can cause problems with electrolyte disorders and worsening renal function, particularly in those that already have low renal function. So to be gingerly used in the older adult population. And then something that we don't always think about is the use of mineral oil as an over-the-counter by older adults for constipation, and that's been clearly associated with lipoid aspiration pneumonia. So with all this good work that we do in terms of deprescribing, how do you track it? And so there's different methodologies, but this is just kind of a mock-up of where we might expect if we had 5,000 patients in our clinical practice, and let's say we identified 3,000 unsafe medications or potentially harmful medications at the onset, and then we systematically applied the 4 M's, that from month to month we would see that the number of unsafe medications should decline over time. And so you can convert this data into overall medication burden, number of pills per patient, for example, or you could do anticholinergic burden and track that over time if you want to focus on that, or you could look at opioids, right? So just simply looking at the number of patients that we've referred for opioid misuse evaluation through our consultant pharmacist. So that would be another wonderful metric to show our efforts towards the deprescribing process and thereby enhancing safety for the older adults. So just to conclude, and then I'll give you one more slide here on resources, is that you want to prepare the patient for reducing medication burden. And a lot of times they're happy to do so. They say, oh, I'm just taking too many medications. But then you've got the other individual that is wedded to their medications because somebody prescribed them for me and I said, never go off of them. So you have to address those types of barriers. I really encourage the use of the Beers list. You can download this off of the American Geriatric Society, or the Dakota Geriatrics program can provide you with a Beers list. And then when prescribing a new prescription, kind of scratch your head firstly and ask if it might be being prescribed to address a side effect of another medication. And that's particularly true in bowel situations with either constipation and or diarrhea. And then people prescribe loperamide, which is anticholinergic, and then, my goodness, they're on Flexeril, and then all of a sudden the anticholinergic burden just, skyrockets and is in outer space. And so you can see how these things can escalate. And then finally, the resources. We have the Dakota Geriatrics website, which I had mentioned, which also has some presentations from our faculty pharmacists that talk about the deprescribing process. I mentioned the American Geriatric Society and the Beers list. And then here's a couple of websites. I quite honestly prefer the Canadian website because it has more practical resources for individuals, and they're a little bit more evidenced, promoting. But both sites have resources and tools for the clinicians, as you can see in this U.S. Deprescribing Research Network. So again, just as a reminder, to wrap up, that please practice the geriatric 4Ms with each clinical encounter, and create an assessment, and then create an action plan linked to each of those assessments. Thank you for your attention.